I now welcome Dr. Sanjeev K. Jha, President IAP, for the welcome and inaugural address. Dr. Sanjeev Kumar Jha has more than 25 years of experience in teaching. Sir has more than 350 workshops, seminars, conferences conducted, and he has treated 25,000 patients all over India and maybe abroad. I welcome you, sir, Dr. Sanjeev Kumar Jha, for the welcome and inaugural address. Welcome, sir.
Thank you, ma'am. It's really an honor to be here on this platform. When I heard about this whole idea of having a conference through NIEPVD, and a topic was really something which we need to promote in whole India. I really thank Dr. Himanshu Das, Director of NIEPVD, and I believe that I met him in Bangalore last time, and it was really a nice interaction with him. And the whole concept of organizing these type of programs, it's really a great thing to be not only for our professionals, because a mixture of the flow from all directions of different stream of healthcare will always come out with something fruitful. So really thank you, Dr. Himanshu Das, for organizing such a different and giving a very nice platform to all of us. I really appreciate the effort of Dr. Krishna Y, President of ISHA, and also the effort of Dr. Ruchi Vasne, Treasurer IAP, backbone of so many functions all across India. And also Dr. Suman Kumar, Secretary ISHA, and all the team of NIEPVD for giving such a good platform. I really believe and thank all of you that you have kept this particular function on 8th of September 2021. And why I am saying all of you thank you, because you have kept this knowingly or unknowingly on World Physiotherapy Day. So from my side, from the side of IAP, to all the physios and all the different associate professionals who are there along with us in the healthcare team, I wish all of them a very happy World Physiotherapy Day. As the theme of the conference says, that teletherapy, you know that we are already going through the difficult time of Corona, and in this pandemic we have learned how to deliver the things from the boundaries of your home or from the boundaries of your house. And when you talk about this Corona pandemic time, this type of topic of teletherapy and delivering best through distant mode to our patient is almost very important nowadays. And this teletherapy theme, I feel all the deliberations and all the talks on this particular topic will be very fruitful, not only for the professionals, but also all professionals will come together and make it fruitful. So I really appreciate the effort of whole team, and I believe that all the deliberations by the various professionals on this platform.
Thank you so much, Dr. Sanjeev Kumar Jha, sir, President IAP, for the welcome and inaugural address. I now move on with our inaugural address and inaugural session, and welcome Dr. Anjali Kant, ex-HOD SLP, for the keynote address. Welcome, ma'am. And if I have to introduce ma'am to the participants and audience over here, presently, ma'am is consulting speech and language pathologist honorary at Voice Tech, Mumbai. Previously, ma'am was the leader and head of Department of Speech and Language Pathology, that is SLP, Indian Sign Language Cell and Medical Department at AYJNI SHD, Dehradun, Mumbai for 32 years. Ma'am is PhD in Speech and Language Pathology and Audiology, and ma'am has got an experience, a total experience of about 37 years in the field of SLP. A recipient of Fulbright Junior Research Fellowship Award 2003-4, affiliated to the University of Texas at Dallas during tenure, audited 2 courses or seminars in CI and hearing aid laboratory, and performance was merited with an A grade. Ma'am was also a principal investigator in many odd projects. Thank you so much for being here, ma'am. I welcome you on behalf of NIEPVD. Welcome for the keynote address.
Thank you very much for the introduction. Good morning. So we all know the current COVID pandemic challenges. Because of the pandemic, we are faced with unprecedented challenges, not only in the provision of healthcare services, but also habilitation and rehabilitation for persons with disabilities. So on one hand, we, even though it's 1 year down the lane, we are not very sure about the pathophysiology, the scale of route for transmission, and the long-term consequences of COVID-19. On the other hand, Government of India has done a good job, has imposed a number of, has done a number of steps, has limited, in order to limit the transmission of the virus. There has been complete or partial lockdown. There has been closure of outpatient services of hospitals and transportation. But what has happened because of COVID and because of lockdown, this has caused tremendous challenges in accessing healthcare services for public as well as for disabled people. Now, what we all know, what is the traditional way of practice? It is physical visits by patients or face-to-face communication, face-to-face consultation. But all of this may pose a risk of exposure to COVID, either from the providers to the patients or vice versa. As a result, the one thing which has happened is global paradigm shift in delivering healthcare services using digital technologies in the form of telehealth, telemedicine, teleconsultation, or teletherapy services. Dr. Hipaa Rules clearly mentioned and explained that how when he was asking the patients, do they want to go to this particular hospital? And the patient would say no, they would rather not go because of COVID. So then the entire shift has been towards teletherapy services. So teletherapy, telerehabilitation, all of us know. Just to put it in very short, teletherapy for persons with disabilities, all types of disabilities. It's very nice to see so many disabilities coming under one umbrella, so many people from various disability areas coming under one umbrella today. It's a very nice concept. So for all disabilities, teletherapy services includes but not limited to telecounseling, consultation, education, monitoring, supervision, patient's functional assessment, preventive measures, various rehabilitation, therapy or intervention, training and demonstration to patients or caregivers, as well as clinical management to certain level. We cannot do everything, but all these things, each one of us will be trying to do at our level best. So how do we go about delivering the teletherapy services? Like, I don't want to just talk about SLP. In between, we will have some examples related to speech and language pathology and teletherapy services, but I'm trying to cover all of this in general. So there are a number of things which we need to do is ethical considerations and requirements. All these considerations will be different for different professionals. So you need to know what are the degree requirements. Can a diploma holder do teletherapy services, provide services? Can a bachelor's or a master's or bachelor's and master, do they need to have a CRR number with RCI? What are the additional requirements? Can I just say that I have done my master's today and I want to now provide teletherapy services? Am I really ready for it? What do I do? How many conferences do I attend? Do these conferences have to be short, long? What should be their content? Should they be the kind of RCI CRE status? Then another point is about awareness. Am I aware of the technology, the products, their cost? A fresh professional may not know so much of teletherapy services, how to provide them, may not know very much about the technology. So all these need to be taken under consideration. Now, technology selection, we need to select an appropriate model of technology as per the client's need. Hardware, whether personal computer or laptops, you need to have the know-how of the hardware, know-how of the technology of the model, selected model, its specification, its calibration, its procedure of operation. You can also provide teletherapy services through mobile phones. I've done a lot of it because patients have been very poor in rural areas, having only mobile phones, no computers, no laptops. Then at that time, what should they have with the mobile phone? Say a WhatsApp app, smartphones. So we can do tele-speech or teletherapy services through video communication. What are the software applications or video conferencing platforms? It can be Skype, Zoom, Cisco, FaceTime. So many of them are there. Which do we use? The rehab professional, I don't want to say SLP, the rehab professional should be aware of all these. That was just in short, it's a lot, but in this much time, I'm trying to give a gist of everything. Then what are the clinical aspects of delivering teletherapy services? It should be equal in quality. One feels that, okay, we will just talk something, give some guidance, and that's it. No, it should be equal in quality to that provided in person. It should be provided by and supervised by a qualified rehab professional, whether a physiotherapist or a speech language pathologist, occupational therapist. They should be qualified. Always it is better that the first encounter should be with the professional should be in person, preferably. In COVID situation that may not happen. There is variability in the client's needs according to their age, whether it's a younger child or an adult, the disorder severe or mild, and any other requirements. Hence, candidacy and appropriateness for teletherapy services should be determined on case-to-case basis, which is based on clinical judgment, clinical informed choice, and professional standards of care, as given by ISHA guidelines for ASLPs. Professionals should be guided by existing scope of practice guidelines of RCI. The scope of practice guidelines will be there for all the professionals, whether speech language pathologists or physiotherapists or occupational therapists. RCI guidelines will definitely be there. Wherever necessary, the professional must recognize the limitations of teletherapy services and recommend the client for in-person consultation testing. Sometimes things may not work. In between, the client may be called for an in-person testing or therapy. While delivering teletherapy services, clinical standards, protocols, policies, and procedures for provision of care should be followed. Now, I will give a few responsibilities of the rehabilitation professional themselves, what they need to be responsible for. Like checking whether the caregivers of the client, whether they have basic facilities for at home for undergoing teletherapy services. For example, I was asked to provide teletherapy services to children with cleft lip and palate in rural Maharashtra. When I contacted them, they said they do not have anything at all, but just a smartphone. Some of them did not have a smartphone also, so they had to borrow a smartphone. So we need to check whether the caregivers of the client, what they have. Then we need to assess the client's candidacy for undergoing the teletherapy services, his cognitive candidacy, behavioral. Now there were many children, 7 to 8 children. This child I have shown because this child was cognitively good, average at least, and he could sit at a place to do all the activities, he could follow instructions. But there are children who get very hyper, they see a mobile phone, they don't want to look at it, and they may get distracted. Then the child cannot be a good candidate. Another thing very important is obtaining a written informed consent for the use of teletherapy services. We cannot just impose this on the client. We need to explain to them. We should have the ability to select appropriate model of technology, which I mentioned earlier. In addition to technology, we need to have things like certain assessment and intervention protocols may need to be modified, may need to be changed, may need to be used differently. For example, if I'll give you an example of speech language pathology. If we are trying to assess the language skills, speech and language skills of younger children, then there are scales and schedules, but there are certain parent-based questionnaires like ages and stages questionnaire instead of other tests, or instead of standardized tests, we can use MacArthur communicative inventories. So there are other assessments or intervention protocols, the peer-based questionnaires, they can be parent-based methods and questionnaires. So there has to be alternations or modifications in the protocols used. We need to be very sure of keeping up appropriate documentation and reports. We can't just take teletherapy. So we can't provide teletherapy services just like that. Today we did this, tomorrow we did that, and we don't know what's happening. That's not the right way. We need to communicate to the caregivers about the progress made and what they need to do. We need to give them some home assignments. Those were just in short. There are so many of them. I've picked an important few. Then responsibilities of the professional along with the client or caregiver. Where is the location of the room where the client will receive the teletherapy services? Is the room well lit? How is there should be comfortable furniture where the child can sit. Now for this child, they didn't have furniture, they had to sit on the ground. Then the environment should be safe and comfortable, and we should ensure confidentiality and privacy of the client. Prior to starting the session, the rehab professional should plan in advance what should be the optimal positioning of the test and therapy materials, where should be the video monitor, the camera. Like before starting our entire session, we have had a session to see whether everything is okay. So the patient also needs to be ready. Then technology used. I'm going a little bit into intricacies of technology. Choose a video communication platform which has got certain basic features. Web sharing, you can see the client can see you. This is with the WhatsApp of the mobile phone, WhatsApp video call. When choosing video communication platform, screen sharing should be there, like how all of us, we know what it is. The screen can be shared, the material can be shared with the client. Just a small short video I will just try.
I have 5 fingers. I have 5 fingers. Drive a van. Drive a van. I like Yelp.
Now, both the therapist and the child, and this is a child with cleft palate, he's nasal, and then the screen is shared with these sentences which are appropriate for his age and he could read them. So this can be done. This is a good way. There should be interactive features for us, for SLP, for physiotherapists and other rehab professionals. It will be different. Allowing client to interact directly with the activities. For example, point or click to the one you drink with. So then this, and then the reinforce or response will be given to the child. Interactive features, like if I'm teaching articulation, then I can select and I can show to the child, and then we can start. If I'm teaching the child ka, the child is saying instead of camera, tamera, he's saying ta instead of ka. So then I have this particular app, and I can select which words I will take, whether ka in the initial position or final or middle. And allowing the client on the other side can also view all these. It will be an interactive session. The client can use this, change the activities or select or respond using his mouse at the other end. I do not want to go into details of synchronous therapy and asynchronous because it will be limited to certain aspects of SLPs. So here is one group therapy session which is going on. Now we go on to the certain administrative aspects of teletherapy services. One needs to develop certain forms and lists. We need to have candidacy criteria, which is very clearly made by our respective organizations like ISHA and IAP. And we need to have consent forms. If it is preferable to have a list of software downloadable at no cost, it will be easy for the rehab professional. List of available hardware or the need to purchase suitable hardware. List of activities in our regional languages. This is I kept an example of speech language for speech language pathologists. There should be a form for recording progress and achievement of goals. All this should be ready. Administrative aspects of teletherapy, reimbursement. We need to be paid for our services. So payments and receipts, clients must be provided with the option of a secure mode of payment. Appropriate receipts must be provided for services provided through telepractice. Now, more so in the Western world, then they will have medical insurance, etc. In our country, that is lagging behind a bit. Then one needs to look at the legal aspects. So we can go through always through Information Technology Act 2000 and Information Technology Rules 2011. They govern the telepractice in ASLP and information technology. For the other rehab professionals, also some things may be there, and you can also look at other acts and rules which will be present, which will be known to the higher ups. Telepractitioners must familiarize themselves regarding these legal frameworks. In the West, you have Hipaa rules, which are very, very strong and being followed very religiously. These acts and rules, they describe the following: data privacy and protection. A client may not want his data to be shared to any and everybody. There has been this one parent trying to tell me that his data should not be shared, or his photo or the child's photo should not be used anywhere for anything. So, and there are some parents who do not mind it. What should be the standard of care, the consent, what happens if there is misconduct, malpractice, and cross-border telepractice. Now the rules may be different. In the United States, if you have to provide teletherapy services, I'm in Seattle right now. So if it is in the state of Washington, I cannot provide teletherapy services to anybody in Florida or any other state. I have to be licensed for that state. So all these conditions are there. We may have in other rehab professionals, or we may be working towards it. So I don't know about this aspect, but we need to be careful about cross-border telepractice. I can think of it in terms of cross-border telepractice in terms of in our country, then different states are there. We have the same rules and regulations, but then the cultural differences slightly may be there. And then the urban and rural areas, things may be different. We can look at those. Cross-border may also mean if we want to communicate or counsel in between inter-rehab professionals, then teletherapy, what happens? Thus, we need it's not to conclude, but to put it in short, we need to consider so many things, so many points while delivering teletherapy services: ethical requirements, clinical aspects, responsibilities of the rehab professionals for himself, herself, along with the client, technology used, administrative aspects, forms, consent forms, etc., reimbursement, and legal aspects. There are many challenges. There will be so many challenges, and all these challenges will be different for different rehab professionals. So I'm sure that in each of the technical sessions, these will be discussed as to the advantages, the strengths, and the limitations of telepractice. How to overcome these challenges will be discussed. So these are my references. I got a lot of material from NIEPVD and a lot of material from professionals who are working for the visually disabled. I was really surprised. There's so many articles. Of course, for speech and hearing there was, but I wanted to look at other perspectives also. I would like to thank Dr. Krishnava. He's always been there for all of us. Honorary President Isha and our very senior faculty, Mahi. And Dr. Suman Kumar, Honorary Secretary Isha and In Charge Assistant Director, AYJ and ISHD, where I have worked for so many years. And he's really been kind. I thank him for giving me this opportunity. Dr. Pankaj Kumar, Assistant Professor NIEPVD, he's been really very good in the sense he's got a lot of issues that going on presently, but he's been able to organize this so very well. I want to thank all the organizers and patrons of this webinar and the audience too.
Have you?
Thank you so much, everyone. I'm sure that this program is going to go on very well, and I'm looking forward to the further sessions also, and we are going to have a real learning experience. Thank you, everyone.
Thank you, ma'am. Pankaj Kumar sir has got an army with him who's working day and night for this program to be a success. Thank you, ma'am. Thank you for the inaugural address and the keynote address. Thank you so much, ma'am. Okay, I now welcome Dr. Suman Kumar sir for the vote of thanks. Dr. Suman Kumar, Assistant Director, Ali Yavar Jung, National Institute of Speech and Hearing Disabilities, Divyangjan. And sir has got the additional responsibility of being the Honorary Secretary, Isha, Indian Speech Language Hearing Association. If I have to speak about sir's total experience is about 20 years, and his areas of interest is speech disorders. Sir has got 22 national publications, 20 international publications, 4 chapters in books, Best Poster Award, served as member of Expert Committee on Inclusive Education of Rehabilitation Council of India, member of Apex Advisory Committee for Development of Higher Education Program in Audiology and Speech Language Pathology of Rehabilitation Council of India, member of Expert Committee to review the topics, norms and guidelines for conduct of continuing rehabilitation education, that is CRE of Rehabilitation Council of India. Sir is an expert member of Assessment and Assessment Accreditation Committee of Rehabilitation Council of India. Served as member of the committee constituted for preparing the draft of the new Act of Rehabilitation Council of India. Member of Apex Advisory Committee of Netaji Subhash Chandra Bose Open University, Kolkata. Member of Academic Council, Netaji Subhash Chandra Bose Open University, Kolkata. Sir, welcome. Welcome you, sir. Dr. Suman Kumar, sir.
First of all, I would like to wish my physiotherapist colleague World Physiotherapy Day, and good morning to all distinguished guests of this program. On behalf of Indian Speech Language and Hearing Association and the organizing committee, I would like to express my gratitude to Dr. Himanshu Das, the Dynamic Director of National Institute for the Empowerment of Persons with Visual Disabilities, Dehradun, for his initiative to organize this multi-specialist, much-needed conference considering the pandemic situation. I would like to thank Dr. Sanjeev K. Jha, President, Indian Association of Physiotherapy, for his association, guidance, and active participation. I would like to also thank our President, Dr. Krishna Vai, uh, for his guidance in organizing this conference. My sincere thanks to Dr. Ruchi Vasni, Treasurer, Indian Association of Physiotherapists, for her active participation, monitoring the program, motivating the participants, and being available 24/7 for providing all possible help and response in organizing this conference. I would like to thank the keynote speaker of this session, Dr. Anjali Khan, for accepting our invitation and delivering the keynote address in spite of her illness and time difference. As you may be aware that she is in United States of America with her son, but and she was suffering from upper respiratory tract infection for last few days, but she has agreed. And thank you, madam, for your valuable input for the program. I would like to also thank the coordinator of this conference, Dr. Pankaj Kumar, Assistant Professor, NIEPVD, Dr. K.M. Annamalai, General Secretary, Indian Association of Physiotherapists, for their active participation and guidance, and facilitating the organizing committee behind the screen. I also would like to thank the program coordinator, Madam Puspanjali, for her constant updates about the program and all her support for conduct of this session. I would like to thank all the team members behind this mammoth task for organizing this national conference, media, technical team, and Rehabilitation Council of India for aggregating this conference as a CRE status. Last but not the least, all the participants and presenters for their active participation. I hope this will be a scientific feast for next 3 days. I thank all the members who have directly or indirectly supported us in organizing this event. Thank you, one and all.
Thank you, Dr. Suman sir. We have come to the conclusion of the inaugural session. Now I welcome the coordinators of technical session 1 to carry on with the sessions. The first coordinator for the technical session 1, I welcome you, ma'am, Ms. Tarushree Tikha, Consultant Occupational Therapist, EIC, that is Early Intervention Center, NIEPVD, Dehradun. Welcome, ma'am.
Thank you, Puspanjali ma'am. Good morning, everyone. Hello to everyone present here. Happy Physiotherapy Day to everyone present here. I am Tarushree Tikha, occupational therapist, currently working in Cross Disability Early Intervention Center, National Institute for Empowerment of Persons with Visual Disabilities, Dehradun. I welcome you, everyone. I, along with my other coordinator, Mr. Rakesh Kumar.
Good morning to all respected dignitaries and participants. Myself, Rajesh Kumar, Assistant Professor, Clinical Psychology, CRG, ma'am.
Sir, I and Rajesh sir will be your session coordinator for technical session 1. I welcome all our guests and our participants. Namaskar. Starting with our technical session 1, teletherapy challenges and its technical solutions. In this session, we will have 5 paper presentations. With the permission of our chair, I would like to introduce our chairperson, co-chairperson, and keynote speaker. Our chairperson, Dr. Neeta Vyas. Namaskar, ma'am. On behalf of our NIEPVD family, I welcome you in this national conference. Ma'am is a physiotherapist who have contributed more than 40 years of her life for enhancement in this field. Currently, she is working in AIMS College of Physiotherapy, Ahmedabad as Emeritus Professor. Previously, she was working as principal at SBB College of Physiotherapy in Gujarat and have served many hospitals there. Also, ma'am is convener and treasurer of Indian Association of Physiotherapy in Ahmedabad. Ma'am have around 50 scientific publications in both national and international journals. With enormous other contributions in the field of rehabilitation, she is always motivated for new challenges and situations where she can offer her experience and knowledge for the benefit of others. Thank you, ma'am, for your presence here. Our co-chairperson, Mrs. Archana Kaushik, ma'am. Namaskar, ma'am. On behalf of NIEPVD family, I welcome you in this national conference. Ma'am is an occupational therapist working in Pandit Deendayal Upadhyay National Institute for Persons with Physical Disabilities, Delhi. She has a rich experience of 16 plus years working for rehabilitation of people of different age groups. Geriatrics being her keen interest of area, she has developed a scale to assess balance confidence in older adults. Thank you, ma'am, for your presence here. We welcome you. Our keynote speaker, Mrs. Akansha Saxena, ma'am. Namaskar, ma'am. I welcome you on behalf of our NIEPVD family in this national conference. Ma'am is a special educator and life skill instructor working as PGT special education teacher in Department of Education, NCT of Delhi. In 20 years of her practice, she has worked with many elite schools of Delhi NCR. She works with various NGOs and rehabilitation centers. She has been a resource person and SCERT and DIET training programs held for principals, educators, and school teachers of Delhi government and MCD schools. She has been awarded with a letter of appreciation from Director of Education for her module on inclusive education. Thank you, ma'am, for your presence here. I welcome all the dignitaries here. From the permission of our chair, moving further with our technical session 1, I would like to request our keynote speaker, Mrs. Akansha Saxena, ma'am, to present her views on our theme, teletherapy, challenges and its solutions, technical solutions. The stage is all your, ma'am.
Thank you so much, Dr. Tarushri.
Yes,
Good morning to all the dignitaries, the patrons, the paper presenters and all the participants. A very relevant topic indeed, teletherapy services, moving ahead for empowerment of and inclusion for persons with disability. Past epidemics, the current pandemic and the eventuality of future outbreaks all necessitate our learning from history to better prepare ourselves to face all adversities. Even after many months into the pandemic, there are no simple or right answers. There are no simple or right answers. It is important to be both proactive, responsive, and innovative while responding to the need of the hour. This is possible only through being constantly updated about the changing situations, learning from other contexts, evolving local solutions, regular reappraisals and modifications in responses, and openness to newer and innovative methods to address the needs and challenges of the patients with neurological, psychiatric, learning, behavioral concerns during the changes phases of life. India is the second most populous country in the world with over 2.68 crore persons with disability, which is 2.21% of the total population of India. 69 from the rural areas and the remaining 31 reside in the urban areas. The number of medical and the paramedical staff, doctors and therapists to cater to all this population is not equally high. Due to this fact, adequate and equitable distribution of healthcare and well-being services has always been a challenge. Teletherapy is an important tool that can combat this mismatch and prove the delivery of healthcare services using information and communication technologies from the exchange of valid information for diagnosis, assessment, treatment, prevention, intervention, guidance of patients and person with disabilities, research and evaluation, and for continuing education of healthcare providers. Teletherapy is becoming very popular in these times of social distancing. Nowadays, isolation is becoming a norm while uncertainty reigns the day and loneliness and apprehension lurks every corner. It is important to take care of ourselves and our children for mental, physical, cognitive, emotional well-being by reaching out for professional help, timely professional help, and continuing therapy. Teletherapy is an remote therapy, any remote therapy that uses technology to help the therapist and client communicate. According to American Psychological Association, APA describes teletherapy as provision of behavioral and or mental health care services using technological modalities in lieu of or in addition to traditional face-to-face methods. Example, provision of therapy using the phone, diagnostic interviewing via video teleconferencing, using of applications to track mood states, consultations via email. In other words, it's a session with a mental health counselor or a therapist that's conducted by other means than in person. It is also called telepsychology, e-therapy, cyber counseling, web therapy, online therapy, or online counseling. There are several different channels that the therapists use for therapy conducted outside the confines of their office or the center. They may communicate via telephone, mail, video conferencing, live chats on website, out messages. Some online therapy platforms even offer a mobile app for video chats or text messages or live demos. These are proving very helpful because the screen sharing helps a lot. The screen sharing along with the therapy or the demonstration, it brings in the live demonstration and the correct methodology to be used by the parents or the caregivers to be given to the children. So, in other words, what are the benefits of teletherapy? They can be many, numerous. They could be relaxation and flexibility with traveling. बहुत सारे पेरेंट्स ऐसे हैं जो अपने स्केड्यूल की वजह से, बिजी स्केड्यूल की वजह से या एक्सेसिबिलिटी की प्रॉब्लम्स की वजह से या डिस्टेंस की वजह से वो थेरेपिस्ट के पास नहीं लेके जा पाते हैं. एंड ऑफ कोर्स ड्यूरिंग दीज डेज ऑफ कोविड सबसे इम्पोर्टेंट बात है सेफ्टी. सो इट्स वेरी इम्पोर्टेंट कि because of teletherapy things have become easier, because now sitting at the comfort of their own homes, the comfort the child and the parents, they along with the guidance and the direction of the therapist, they can deal with the children at the home scenario. Along with it, they just have to do is the click of the they just have to click the link that the therapist has sent and they can carry on. Apart from that, there are other things also. If the parents have the they have the financial constraints, they have the time problems, they have the stigma problem. बहुत सारे parents ऐसे होते हैं जो maybe openly therapy के लिए नहीं आना चाहते हैं. They have this stigma कि we don't want to go to the therapy center. So this is a boon to them कि they can at their own home fronts, they can take the consultation and the intervention. Right. Apart from that, the cost effectiveness is also there and the time management is also there. Parents अपने हिसाब से भी time दे सकते हैं. ठीक है. The services provided by the audiologist, speech language pathologist are also included in the term that is used these days is tele rehabilitation. Okay, so tele practices, the venues, they are included in schools, medical centers, rehabilitations, hospitals, community health centers, outpatients, clinics, the universities, the clients' homes, the residential healthcare facilities, the child care centers, in numerous, the corporate settings. There are the inherent limits, but if implemented in the right earnest, they can definitely help the parents and the children. But along with the benefits, there comes some deficits also, or some lacunae, which probably worked upon can be helpful. The main problem to do is with the online, the parents always have this concern, is online therapy okay for my child? Will my child respond to the online or the screen therapy? My child has the sitting or the attention to take the therapy sessions. So there are a lot of questions that goes on in the minds of the parents. They also have the constraint of the space. Sometimes they don't have the resources to work with the therapy. Maybe the lighting arrangement, which I feel Miss Anjali Kant ma'am also emphasized, that there should be complete atmosphere at home to take the tele sessions, right? So the preparedness to eliminate some of these disadvantage, if can be done, can be very it can act like a boon. There could be technological and the technical hitches. We know about the connectivity issues, so there could be these connectivity problems that can help. So if these problems are resolved and if we get the complete cooperation of the parents, then it can be a very helpful thing, right? So teletherapy is an ideal option for people who find it difficult because of their busy schedules, or because they cannot move on from one place to the other, or they have moved from one place to the other, but they want the same therapist to carry on. So it's very good for them, and also children who have accessibility issues, for them also it's good. And of course the limitations, we also know one of the very big limitation is that even if the parents, they try to guide and they try to make the parents understand even by demonstration, but कई बार parents को नहीं पता होता कि कितना push, कितना pull, कितना stretch देना है. तो ये जो limitation होता है, ये या आपने instruction कैसे देने हैं या कितना prompt देना है, तो ये जो issues आते हैं वो if can be covered up in the right way by right guidance. So it's a very nice time where the parents or the caregivers can actually become partners in the therapy session. So now it's time for the parents actually to take this partnership along with the therapist, so it can come a long way. The challenges, of course, again could be there, including lack of control over the environment. Sometimes there are so many distractions at home. The child also keeps on running because it's the comfortable zone, and probably it's not the time for the child to sit at that place, or the child has not learned to sit in that home environment. So the environmental constraints definitely are there. The privacy and the confidentiality, sometimes the parents feel that if we give the information and such a forums comes, what will happen to their privacy. So that's one. Then therapeutic alliance without face to face contact. जब फेस टू फेस कांटेक्ट नहीं होता है तो बहुत सारे ग्लिचेस आ सकते हैं. बच्चे की बॉडी लैंग्वेज है, उस समय अगर बच्चे के साथ किसी तरह का बिहेवियरल इरप्शन आया है, तो इमीडिएट इंटरवेंशन क्या देना है, किस तरह से देना है, तो ये चीजें नीड्स टू बी टेकन केयर ऑफ. सो ये एक हिच होता है जो ट्रेडिशनल वे ऑफ थेरेपी में, एंड नाउ विद द मूव्ड ऑन द लेटेस्ट थेरेपी वी नीड टू इवॉल्व. Then people are realizing, then tending timely therapeutic intervention, because people have realized that children have reverted back without the timely intervention or the therapy which was to be given in the critical time, taking care of the milestones and the age. Children have reverted back. Some parents kept on thinking and waiting, time will come, maybe we will come out, maybe we will seek for guidance, maybe we will get in touch with some therapist, but the but kept on enhancing and increasing to the time that it's almost 2 years, that now the parents have realized that the children are reverting back and they need now the intervention. So a lot of things have to be undone, the time has to be brought back, things have to be covered up. So now the crux of the hour is that we actually get to the root of things and modify and adapt things to suit to the benefit and welfare of the children and the parents. So the parents also need to be consoled and comforted that it is for the betterment and together we'll do it. So it's time that this thing gets created and gets advocated, that we are there for you and together we'll do it, right? So teletherapy, I definitely feel, is a good option. It can also prove beneficial to for the entry and for the people who have barriers for the first time consultation. You know, they have been sitting in the confines of home because it's a very important decision to take to seek for an intervention. So for any parent to accept things and to seek for an intervention, it's very important. So again, it's important that the professionals, the right, the key thing is the selection, getting in touch with the professional and seeking help, which needs some exploration, but one needs to do it. So ma'am has already spoken about the synchronous and the asynchronous, wherein the audio and the video tapes are given, and in the synchronous type of therapy, while in the asynchronous, the photographs and the videos are taken and given from time to time whenever required, whereas the hybrid type of intervention and the tele practices wherein you use the face to face also and these type of therapies also. With all said and done about teletherapy, it's very important that we understand our role and responsibilities. As professionals, what is our role and responsibility? So it's very important that we know the outcomes before we actually devise the objectives. What is the outcome we are expecting from what intervention we are giving? So do we have the right type of things with us? Are we using the correct language, the what we are catering, the group of people we are catering? तो हम किसको address कर रहे हैं? जो ग्रुप है वो क्या कौन सी लैंग्वेज का है, वो हमारी किस तरह से बात समझ सकता है, उस उनके लोकल एरिया में किस तरह के टूल्स या मटेरियल अवेलेबल होता है जिसका हम बेस्ट यूज कर सकते हैं, उनके पास एनवायरनमेंट में ऐसा क्या है जिसकी हम एज अ बेस्ट रिसोर्स तैयार कर सकते हैं. सो ये बहुत ज़रूरी है कि हम पहले खुद इफेक्टिवनेस अपनी क्रिएट करें एज प्रोफेशनल्स, और हम उनके नज़रों से देखें, बी एम्पैथेटिक एंड try to adapt and modify our methodologies to suit to the child's level. And along with it कि ये बहुत ज़रूरी है जानना कि बच्चे की limitation and sensory problems क्या है. You just can't start therapy like this जबकि बच्चे के diverse needs हैं, बच्चे के बहुत सारे issues ऐसे हैं which we need to take on. So बच्चे की hearing ability कैसी है, बच्चे की visual ability कैसी है, उसका manual dexterity कैसा है, उसका physical endurance कैसा है. आप किसी पेरेंट को जनरली नहीं बोल सकते कि अच्छा एक्स की एक्टिविटी स्टार्ट कर दो या किसी और तरह की एक्टिविटी स्टार्ट कर दो टिल यू एक्चुअली नो द बैकग्राउंड एंड द लेवल ऑफ फंक्शनिंग ऑफ द चाइल्ड. सो it's very important that we actually take a complete case study and we know before planning and before executing our plan. So the cognitive, behavioral and the motivational characteristics of the child, the level of maintaining attention, sitting in front of the camera, is the child scared of it, या बच्चा टीवी या कुछ और चैनल्स या कुछ और देखता है, तो किस तरह से हम पिक्टोरियल्स के थ्रू या एनिमेटेड फिल्म्स के थ्रू we can actually develop a connect and then start moving. विलिंगनेस कितनी है फैमिली की, केयर गिवर्स जो होम सिचुएशन है वो कैसा है, कम्युनिकेशन कैरेक्टरिस्टिक्स कैसे हैं, बच्चे की ऑडिटरी कॉम्प्रीहेंशन कैसा है, उसकी लिटरेसी कैसी है, उसकी स्पीच एलिजिबिलिटी कैसी है, इंटेलिजिबिलिटी कैसी है, उसका कल्चरल लिंग्विस्टिक वेरिएबल्स और बैकग्राउंड क्या है, और क्या कोई इंटरप्रेटर अवेलेबल है. अगर आप अपनी बात कन्वे नहीं कर पा रहे तो क्या जना कोई अवेलेबल है जो आप दोनों को कनेक्ट कर पाए. रिसोर्सेज कितने हैं, टेक्नोलॉजी कितनी है, कनेक्टिविटी कैसी है, फैसिलिटेटर आप एज अ कैसे हो, आप डायरेक्शंस जो दे रहे हो उसको किस तरह से लिया जा रहा है, होम बेस्ड टास्क कितना आपने दिया है. सो इट्स वेरी इंपॉर्टेंट दैट यू नो द एनवायरमेंटल कंसिडरेशन to ensure the comfort, safety, confidentiality and the privacy of the clients. It's very important to see that the minimized sound and the visual distractions has been done so that you get the required results. Apart from that, just 2-3 more things. It's very important that the caregiver, the clinicians or the tele practitioners, they have the specialized knowledge and skills in selecting assessments and interventions that are appropriate to the technology and take into considerations client and the disability variables. Assessment and therapy procedures and materials may need to be modified and adapted according to the lack of physical contact with the client. So as professionals, we are playing a very pivotal role in the lives of children and clients. It is important that we consider the importance of the hour and accordingly adapt ourselves for the benefit of people who approach us and reach out to the others who require our guidance, intervention, knowledge, adaptability, modifications, and therapy. I really thank the team, Ms. Tarushri and the complete team for calling me so that I can apprise you and I can talk to you about the teletherapy, which is the upcoming thing, and we need to adapt and prepare ourselves to reach out to many children and many parents and do a bit about it as professionals. I wish luck and best wishes to all the presenters and wish their papers bring out some learning so that we all are able to enrich ourselves. Thank you so much. Thank you.
Thank you, ma'am. Thank you for this wonderful session, wonderful discussion.
Thank you
It
so
was
much.
such a great talk, ma'am. Our participants must benefit from this. Thank you, ma'am.
Thank you. It was my pleasure, ma'am. Thank you.
Rajesh sir, now I would request you to please take over from here.
To all respected dignitaries and participants, with the permission from our chair, I would like to start with the paper presentation of our participants. In that session, first of all, I would like to invite Ms. Ayushi Chandresh Kumar Shah for her paper presentation on the topic of post-COVID-19 functional status and its correlation with fatigue. Ms. Ayushi Shah, ma'am, please present your paper now.
Very good morning, everyone. And the topic for my presentation is post-COVID-19 functional status and its correlation with fatigue. We all know how COVID has affected us and the population worldwide. But now it has led to a serious consequence, that is the long haulers, the individuals presenting with post-COVID-19 symptoms. It is expected that it may have a principal effect on physical, mental, cognitive, and functional status of an individual. One of the most common post-COVID symptom is fatigue. So let us see what fatigue is. It is basically the decrease in physical and or mental performance that results from changes in central, psychological, and peripheral factors due to COVID-19 disease. It is also observed that in the post-COVID phase, the recovered individuals are susceptible to reduced functional status and their ability to perform usual activities of daily living is also affected. In coronaviruses are generally more associated with arthralgias and myalgias, and the most widely accepted theory for that is the immune-mediated mechanism. Due to increasing in the number of the subjects suffering from COVID-19 as well as those recovering from COVID-19, there is a need to measure and monitor the impact of the disease on the functional status as well as how it is correlated with fatigue. With the paucity of literature addressing the post-COVID-19 consequences, the current study aims to assess functional status of the COVID-recovered individual, its correlation with fatigue, and the prevalence of musculoskeletal symptoms in the COVID-recovered individual. Methodology: a Google survey form was generated. It consisted of 12 questions and 2 scales. Initially, it was generated in English, and then linguistic translation was done so that it gets accessible to everyone. And then it was circulated via various social media portals. Only those who were affected within last 3 months of infection were included, and they were assessed via Google Forms for demographics, healthcare utilization, month of infection, date of 14 days quarantine completion, the vaccination status, the symptoms at the time of onset, presence of myalgia or arthralgia, fatigue using fatigue severity scale, and functional status using post-COVID-19 functional status scale. This post-COVID-19 functional status scale is composed of 5 grades. Grade 1, which indicates negligible functional limitation, 2 slight, 3 moderate, and 4 severe functional limitation. And fatigue was measured using fatigue severity scale, and the respondent had to answer on a Likert scale ranging from 1, which indicates completely disagree, to 7, which indicates completely agree. Analysis was done using Microsoft Excel and SPSS version 16. Results: 100 post-COVID-19 patients participated in the study with mean age of 34.08. 86% participants were within 1 month duration, whereas only 14% participants were within 2 months duration. 49% of the participants were male and 51% were female. 91% of the COVID participants were managed in home quarantine during their COVID-19 infection. 76% of the individuals had not taken any vaccination. 38% of the COVID recovered individuals experienced musculoskeletal symptoms in the form of myalgia or arthralgia. Fatigue was observed in 61% of the COVID-19 recovered participants, which is a huge number, and out of which 52% were within 1 month and 9% were within 2 months duration of post-COVID-19. Functional status, 55% of the COVID recovered individual had no functional limitation, 29% had negligible functional limitation, 13% had slight functional limitation, and only 3% had moderate functional limitation. Spearman's correlation test was applied, and it was found that there is moderate positive correlation between fatigue severity and functional status with correlation coefficient of 0.507, statistically significant at p-value less than 0.01. There is weak positive correlation between functional status and age with correlation coefficient of 0.202, statistically significant at less than 0.05. Discussion. As we have already seen, a huge number of participants, that is 61%, experienced fatigue after infection with COVID-19. In accordance with this, Townsend et al. Demonstrated that there is significant burden of fatigue in individuals after COVID-19. And he also highlighted that it must be assessed irrespective of the severity of initial illness. Though we clearly do not know the mechanism, but one of the most likely explanation for this is the neuroinflammation in the brain or the systemic inflammation which activate the innate immune system in the brain. Now, how exercises can be helpful in this? Exercises would basically stimulate the immune system by inducing mitochondrial adaptation, cell generation, and immune surveillance. It also releases anti-inflammatory cytokines, which leads to inhibition of pro-inflammatory cytokines. And these are the beneficial effect of exercise on immunity. Hence, individually tailored exercise prescriptions must be given to post-COVID-19 patients so as to enhance their immune function. As we have already seen, diverse degree of functional limitation was found in our study ranging from negligible to moderate. In accordance with this, a study conducted by Jacob LG et al., he demonstrated that the symptoms often persist up to 35 days post-hospital discharge, and they often impair the ability to perform activities of daily living and quality of life, which was consistent with our study. Bailey et al. Had demonstrated that post-COVID-19 patients who were discharged home after hospitalization showed severe disability, and they would require rehab to recover their prior functional status. And as we have already seen, there is increased burden of fatigue in post-COVID-19 patients, also considering that it might be present even months after the end of the disease. In this context, the present study is an attempt to determine if there is any correlation between fatigue severity and functional status, and how fatigue impairs the functional status in the post-COVID-19 patient, which we found that there is a moderate positive correlation between them. Carbo-Shedal et al. In a study described the predictors of symptom persistence, and it was found that the persistence of the symptom was significantly associated with age 40 to 60-year-old, which was inconsistent with our study, in which weak positive correlation was found between functional status and age of the patient. 38% experienced myalgia and arthralgia, which was consistent with the study conducted by Sykes et al. In the present study, there is a lack of data of functional status before COVID-19 infection. The pharmacological therapy given to the patient was not known, and the region of the body affected for musculoskeletal symptom was not included, which can be addressed in the future studies. Regardless of this, these preliminary results are shared so as to inform the long-term health-related outcomes of the COVID-19 recovered patients, and these findings may be important for health service planning as well as for the planning of the treatment of the survivors of the COVID. The conclusion is that after COVID-19 infection, there is increase in the prevalence of fatigue. There is a diverse degree of functional limitation ranging from negligible to moderate, and there is moderate positive correlation between fatigue severity and functional status. These are my references. Thank you very much.
So now I would like to request our chair, If is there any questions, please ask to presenter Ayushi Chandresh Kumar Shah.
Ayushi, your presentation was really nice. I'm impressed by the scale that you're trying to make. I want you to take it forward. And one thing I wanted to ask, when you had prepared the questionnaire, was there a peer review kind of a thing done for face validity at that time or no?
No, ma'am, there was no face validation, ma'am. Actually, the questions which were included, they were basic like demographic and the status, and the scale which were included, we had taken permission from the author for post-COVID-19 functional status scale and the fatigue severity scale. But no as such validation was done for questionnaire other than that.
Okay, so the scale is already there and you've used it, right?
Yes, ma'am. The scale were already there, and I had taken permission from the author to use it.
Great, good.
Thank you, ma'am. Thank you so much. So, presentation की अगली कड़ी में अब हम invite करेंगे Mr. Binoy Matthew KV. His paper presentation topic is effectiveness of tele-rehabilitation during the pandemic. What evidence says. Mr. Binoy Matthew KV, please present your paper now.
Good morning all. I would like to present the paper, Effectiveness of Tele-Rehabilitation During the Pandemic, What Evidence Says. First, coming to the introduction, widespread of the COVID-19 infection worldwide has forced World Health Organization to declare as a pandemic in the early month of 2020. COVID-19 pandemic has forced governments to use mobility restrictions to protect the children and persons with special needs. And because of that, the physical access to physiotherapy, occupational therapy, speech therapy, and special education services, which are integral for the effective rehabilitation, has been severely hampered. Hence, tele-rehabilitation was extensively used during those time from the commencement of the pandemic and enforcement of travel restrictions across the world. And though it was extensively used, the effectiveness of this approach could only be established with research findings among the stakeholders involved. So we conducted a literature search and did a narrative review to verify the effectiveness of tele-rehabilitation. Coming to methodology, the narrative review used extensive search on databases like PubMed, ScienceDirect and Web of Science. The keyword used were COVID-19, pandemic, disability, new normal, children with special needs, rehabilitation, online, teletherapy, tele-rehabilitation, online therapy, virtual therapy, consultation, and counseling in various combinations. The search was restricted to clinical trials and systematic review works published in English from January 2020 to June 2021. Only studies which discuss any mode of tele-rehabilitation with physiotherapy or exercise as a component among children or persons with special needs and their care providers were only included. Coming to results, 26 studies met the inclusion criteria. Each full text article was individually read by the authors and documented. The studies were among diverse disease conditions, and children and persons with various disabilities access services through tele-rehabilitation, which was found in the studies we evaluated. And the discussion, we have classified the studies based on the level of evidence as proposed by Sackett and Ackley. And coming first to the level 1 evidence, systematic review and meta-analysis study of RCTs done among stroke subjects shows that there is moderate quality evidence that no difference in activity of daily living between people who received a post-hospital discharge tele-rehabilitation intervention and those who received usual care, and low quality evidence that no difference in effect on activities of daily living between tele-rehabilitation group and in-person physical therapy program group, and low quality of evidence that no difference between tele-rehabilitation and in-person rehabilitation for balanced outcomes. And there is insufficient evidence to draw conclusions on the effect of tele-rehabilitation on mobility or participation satisfaction with the intervention. Another systematic review evaluated the effectiveness of tele-rehabilitation intervention and compared it with traditional rehabilitation services for therapeutic purposes among the elderly group, and it found no significant difference between both the mode of therapy delivery. Another systematic review was conducted to evaluate the effectiveness of pediatric tele-rehabilitation interventions which was offered to children with special needs or to their families, And it was found that the effective interventions were the ones which targeted parents, which was centered around an exercise program, which used an coaching approach, and which was focusing on modifying the children's behavioral functioning, and the duration was more than 8 weeks, and which was delivered at least once a week. And another systematic review evaluated the efficacy of integrated tele-rehabilitation approach on motor, cognitive, and participation outcomes in persons with multiple sclerosis. It showed that the overall effect was large for motor outcomes and the effect was small for cognitive performance outcomes and participation outcomes. Another systematic review evaluated the exercise-based tele-rehabilitation on pain, physical function, and quality of life in adults with physical disabilities. Because of the low quality of studies and small sample size, it was impossible to state the efficacy in short term as well as in long term. Another systematic review evaluated the effectiveness of internet-based tele-rehabilitation among persons after total joint arthroplasty over the domains of pain, range of motion, physical function, health-related quality of life, satisfaction, and psychological well-being. It shows that comparative effectiveness is there in relation to face-to-face rehabilitation. Next comes the level 2 evidence. A 3-armed RCT was conducted to evaluate the cost effectiveness of vestibular rehabilitation, and 3 mode of therapy delivery, that is standalone vestibular rehabilitation, was compared with blended internet-based vestibular rehabilitation and usual general practice care. It was found that standalone visual rehabilitation has the highest probability to be cost effective compared with usual care. And the mixed study, where one component was the RCT, shows that effectiveness of 2 differently formatted training programs in educating nighttime postal care among care providers of children with cerebral palsy, and it found that the tele-rehab mode of delivering intervention didn't lead to any greater improvement in actually improving the ability of the caregivers to position the child. Next is level 2 evidence 2B. RCT evaluated the effect of 12 weeks of home-based motor training tele-rehabilitation, and it compared over conventional rehabilitation in stroke subjects. It found that there is a beneficial effect in motor function, and the tele-rehabilitation helped in enhancing interspheric functional connectivity of the primary motor cortex areas which are related to movement. Another stroke related RCT evaluated the effectiveness of stroke interactive virtual therapy STRIDE intervention on upper extremity clinical outcomes with outpatient therapy provision. It found that clinically meaningful improvements in gross upper extremity motor function was achieved with this tele-rehab mode. And the RCT compared outpatient physiotherapy care via tele-rehabilitation to in-person physiotherapy care among total hip replacement subjects. And there was no between group differences, but the tele-rehabilitation group were more compliant with the home exercise program. Next was the RCT, which evaluated the functional recovery of older adults with hip fracture. A multidisciplinary tele-rehabilitation program was compared to home-based in-person rehabilitation. It shows that tele-rehabilitation program group achieved higher functional independence measure scores and better performance in the time up and go test, but not statistically significant findings in short physical performance battery scores. Another RCT evaluated a nurse-trained, family member-delivered rehabilitation program, and it evaluated the functional recovery among stroke patients, and it shows that the tele-rehabilitation mode improved physical recovery without increasing caregiver burden. Another study RCT was titled Singapore Tele-Technology Aided Rehabilitation in Stroke, STARS. It evaluated the effectiveness of home-based tele-rehabilitation among stroke subjects, and it found that similar improvement was possible like inpatient therapy in functional outcomes. Another RCT evaluated the effect of the internet-based physical activity and exercise promotion program on domains like fatigue, quality of life, and gait in persons with multiple sclerosis. It was found that the in-person therapy effect was maintained using the teletherapy mode for 3 to 6 months. And another multi-site RCT evaluated the self-directed usage of in-home exercise after a supervised tele-rehabilitation program among older adults with low limb amputation. It found that the duration of exercise was maintained during the tele-rehabilitation phase, but the frequency of exercise sessions got reduced. And the RCT evaluated the adherence and effectiveness of 8-week home exercise program for children with disabilities delivered using PhysioTrack, which is an online exercise designing platform to traditional paper-based method, and it found no difference between the two modes of exercise designing. And the pilot RCT evaluated the effect of web platform aimed to support parents of children with suspected or diagnosed developmental coordination disorder, and it found that there is no statistically significant difference between virtual consultation mode as well as provision of online resources to parents of children with such disorders. And another study evaluated